Good afternoon, ladies and gentlemen. Welcome to this course on the ocular surface disorders. And we're going to try with Quresh and Dr. Vanathi and Rajesh and Rohit to try and clear up some of the latest that's on in this area, as well as if there are any confusions, discuss the changing paradigms. And that's really the course. So we've been doing this now for a few years at the AIOC. And it's evolved, and as you will see, there's a little bit of an evolution that happens each time we have something new developing. We also have new things being discussed in this course. So can I go on to the next slide, please? So this is what the structure of this course is going to be. We'll start with having Dr. Maskati tell us about what's really troubling the patient from a clinical point of view. Then we'll see how there are other areas or other aspects of the ocular surface disorders which mimic the dry eye and discuss those. And then Dr. Vanathi will be talking about how to choose an appropriate artificial tears and the conventional management of dry eye syndrome. Dr. Rohit Shetty is going to be telling us about the role of vitamin D and how the inflammation is coming up in a big way in ocular surface disease. I'll then be talking about the hyperosmolarity and osmoprotection, something that's been there now for close to a decade, but it's still something that we haven't all got hold of yet. And then Dr. Rajesh Sinha is going to come up with 3 small talks. First on Meibomian Gland Dysfunction, the second on a new paradigm called OHHQ and the post-surgical dry eye, and then talk about topical chloroquin, which is a newer molecule which is available for dry eye disease. Dr. Vanathi will then complete, along with Dr. Maskati, the talk on Cyclosporin and how effective it is and what's the latest on Cyclosporin. And then Rebamipide, which is a new product which is available now to us. And that would then conclude. And we will then have a panel discussion as well as answer questions from the audience. And if there's anything at all, just feel free to ask us. It is an instruction course in the end, so we like it to be interactive as much as possible. So just raise your hands, and even if it's in the middle, I don't mind at least. Even if it's in the middle, there's something that you'd like us to elaborate on, please just interrupt us, no problems. Next slide, please. We will, of course, initiate proceedings with our honored guest, who will be delivering a keynote address on the therapeutic use of scleral contact lenses. And please welcome Dr. Mark Rosenblatt, who's the professor and the head of department at the Illinois Eye and Ear Infirmary at the University of Chicago. Dr. Rosenblatt, please.
Thank you so much. It's really a pleasure to be here. I want to thank the organizers for inviting me and also, of course, for being so hospitable. It's really a beautiful conference and really infused with a very special culture. I appreciate that. I hope that my talk isn't like OSD and is neither concerning or confusing, but hopefully it'll make a few things clear. This is an area that is of great interest to us in Chicago, but I think also has a great deal of interest here in India as well. It's use of scleral contact lenses to treat ocular surface disease. These are my disclosures. None of them are relevant to this talk. So scleral lenses are important that they don't touch the cornea. Essentially, a fluid reservoir is contained within the space between the cornea and the lens, and therefore leaves the cornea unperturbed. And on the right, you can see a diagram where you have haptics which touch the scleral portion, hopefully clear the limbal region, and then vault over any ocular pathology. And beneath this vault is this refreshing liquid that should keep the cornea in a pristine state. This idea of scleral lenses aren't new. Leonardo da Vinci, like he thought of many things before many other people, thought of these kinds of lenses in the 16th century. And over time, there were various iterations of scleral lenses. I won't go into the details, but currently there are dozens of types of scleral lenses. I think there's even some originating here in India that are very special. So although I'm going to talk about one particular type of lens primarily, which is the PROSE lens, which stands for prosthetic replacement of the ocular surface ecosystem, which is sort of the most customizable version of the lens. Most of the things I'm talking about are actually relevant to all types of scleral lenses, so that's an important element. So the PROS lens was developed at Boston Foundation for Sight. It's fluid ventilated. It has a unique liquid corneal bandage. It has diameters ranging from about over 17 to up to 23 millimeters, high DK, and there are about 12 sites in the US that fit these lenses, and I believe 3 here in India that are able to make these lenses. And the lenses are highly customizable. There are many different free parameters. You use computer-aided design software. But much like a suit, I actually need a tailored suit to even look half decent, but many of you can buy suits off the rack and look great, so not everyone needs a PROS lens to have the therapeutic benefits of a scleral contact lens. So the 2 indications, went forward here a little bit, the 2 primary indications are corneal irregularity or ocular surface disease. And so Perry Rosenthal, who is sort of the father of the Boston scleral lens, did some studies and published a large series of patients looking at all the different myriad clinical indications. These can include corneal degenerations like ectasia, corneal dystrophies, other things that cause ocular surface irregularity, including aphakia or myopia. And all of these are useful uses of the corneal irregularity aspects of the scleral lens. And probably most importantly for this session is the use in ocular surface disease, including corneal stem cell disorders like Stevens-Johnson syndrome, OCP, neurotrophic conditions. We use it quite a bit in ocular graft versus host disease in our institution, and other types of severe ocular surface disease that aren't amenable to other therapies. And so the outcomes are quite good. If you look at improvement in visual acuity, almost all patients who are able to tolerate the PROS devices ultimately have improved acuity, but also importantly, when you look at the VFQ-25 function, they see better, they have less pain, and their overall mental health is improved. So these can actually, and their dependency upon others decreases as well. So here's some examples. A man with keratoconus, 56-year-old, can't wear his contact lenses, even though the contact lenses give him good vision because atopy. By putting on the contact lens, it shows that he has keratoconus. You see there's a nice vault. There's an area of fluid underneath the lens between the cornea and the scleral lens, and he's now able to tolerate the contact lens because the lens forms a shield against the environment in the lids, creates an expanded tear reservoir. So he's able to have 20/20 vision and now tolerate this kind of contact lens. A patient with Stevens-Johnson syndrome, 29-year-old man with Stevens-Johnson syndrome from age 9. Bilateral buccal grafts, but now has tried every sort of topical medications on frequent anti-inflammatories, frequent artificial tears, but still has visual acuity of 2400 and count fingers. You can see there's sort of typical findings for limbal stem cell deficiency and opacities after this very serious disease. But after getting a good fit with a PROS device, he's able to be comfortable, he's able to wear the devices, and more importantly, his acuity initially improved to 20/21/5 and 2200, but later further improved to 20/70 and 2100. So you're not just treating the irregular astigmatism or just the corneal irregularity, but the actual corneal haze began to improve as well with the lack of inflammation. Third case, a young patient with familial dysautonomia, so chronic epithelial defects secondary to neuropathy. 2200, 2060. Her parents are putting artificial teardrops in her eyes every 15 minutes. It basically destabilizes the entire family. But with the ability to put on a PROS device, you get the vision improves ultimately to 20/70 and 20/50, but more importantly, she's able to now become independent because instead of putting tears on the drops every 15 minutes, you have an expanded tear reservoir that stays constantly on the eye and allows the patient to function well. 94-year-old man with a persistent epithelial defect after multiple surgeries. All conservative measures to cure this patient's epithelial defect didn't work. So by keeping 24-hour wear of the contact lens, you see the epithelial defect at day 1, at day 4, at day 5, and ultimately by day 7 you have complete closure of the epithelium. Essentially this is by wearing the PROS device 24 hours a day. So we've published on using a chronic wear of the PROS device in a standardized fashion to allow epithelial defects to heal without concomitant infection, which was a prior problem. Which of these patients has pain? You'd say the patient on the right, but actually the patient on the left was threatening to commit suicide due to her severe dry symptoms, sharp pain, debilitating pain. But by putting a PROS device on, she got immediate relief. And within 15 minutes, her life had changed. So this isn't a panacea. It doesn't affect everyone the same way. But neuropathic pain can certainly be destabilizing, acute versus chronic. There's central sensitization. And by basically taking all the sensations that can hit the cornea, temperature, drying, and a mechanical sensation is basically all blocked by the PROS device, this patient now no longer has this neuropathic pain. Hyperesthesia, allodynia is able to lead a normal life. We've looked at the way in which the scleral device can change the lacrimal functional unit, or the nerves of the cornea. We hypothesized that extended wear will change the way the nerves function and the tearing happens. We looked using Schirmer's testing and Cochet-Bonnet anesthesiometer, and saw that in patients with corneal irregularity, tear production actually improved and corneal sensation improved. Those with ocular surface disease, however, didn't have as robust a response. We looked at corneal nerve changes and saw that actually there was no change in the nerves, but just structurally, but the function of the nerves were altered. Keeps going forward. At any rate, if we also look at complications, these aren't perfect devices. If air bubbles get caught underneath the lens, that can be problematic for patients. In patients with quite a bit of inflammation, there can be mucus, so treating the inflammation still with topical steroids or other immunomodulators can be important. Conjunctiva can ultimately come underneath the lens. This usually doesn't affect vision, but can be disturbing to the physician looking at the patient. If there's poor fit at the limbus, it can cause limbal stem cell deficiency or limbal stromal edema. There can also be lack of oxygenation to the cornea and bullae, particularly if the vaulting over the cornea is too high. There can be apical touch, in which case vault has to be increased. This is a case of severe keratoconus where the cornea is actually touching the device. And there can be dryness, of course, in areas that aren't covered by the lens. And the conjunctiva, although it has less sensitivity than the cornea, can still have symptoms of dryness, so it doesn't help all patients. We were very concerned that maybe this is a difficult device to put into the eye. You saw it's quite a big contact lens. So we looked and saw how does the ability to fit these lenses change with diagnosis and also with age. So we stratified patients into ocular surface disease or corneal irregularity and looked at patients who were less than 60 years old or more than 60 years old, and found that actually all patients were able to be fit very well. So within 2 to 3 weeks of starting use of the lens, patients were essentially up to full-time wear, which is greater than 8 hours a day. By the 7 or 8 week, all patients, whether they're younger than 60 or older than 60, were able to keep these devices in for up to 12 hours. So it wasn't that hard to fit them. The time it took the patients to insert the devices, once they learned how, actually didn't vary by age, and actually their overall difficulty rating was always low on a scale of 1 to 5. So these patients are highly motivated. They need these devices, so they're willing to take the time to learn, and those that do are highly effective. We've had patients as old as 90 and as young as 6 or 7 years old using these devices effectively. A couple of other considerations. One is that scleral lenses can be used particularly as a drug delivery system. It has been tested using Avastin to treat corneal neovascularization by my colleagues in Boston. And we have used serum tears, as have others, as well as other immunomodulatory agents within the device for sustained exposure. You know, the problem with an eye drop is it's only on the ocular surface for just a few minutes, whereas you can maintain high concentrations and high corneal delivery of drugs by putting them into the reservoir. Also availability. In some parts of the world, corneal tissue is hard to obtain, and in others, scleral devices are hard to obtain. In many areas, it's both. But by using these devices, you can often avoid certain surgeries, particularly for ectasia, and the widening availability of scleral lenses of many types are making it more available. And finally, affordability. The Boston scleral lenses in the U.S. can cost up to $8,000 to $9,000 to fit both eyes. I think here in India the costs are lower at the 3 centers, but they're still prohibitive for many people. Some of the non-customized lenses, the ones that are a little bit more off the shelf, are much more affordable, and I think are be available for help our patients. So scleral lenses are, I think, a powerful tool to have in your toolbox as you begin to treat patients with severe ocular surface disease. It doesn't help everyone, but in our clinics, it's been a tremendous benefit for a significant number of patients. So thank you.
Thanks very much, Dr. Rosenblatt. That was a wonderful, very short summary of the way scleral lenses are used. They are expensive, but when they work, I don't think there's any comparison really with what they're able to deliver. So thank you so much, and thank you for being here at the AIOC this year. We're going to go into the main IC now and start with Dr.Quresh Maskati, who's going to initiate the IC.
Okay, so basically when we're tackling an ocular surface which doesn't look quite healthy and the patient is cribbing and complaining away to glory, we need to first make sure that we know whether we are dealing with allergy, infection, or dryness, or a combination of them. Many times there is a combination of one or more, so we need to find out what we are dealing with. So this 7 minutes is to just try and unconfuse the confusion. So it's easy when there are classical features. For example, in an ocular allergy like this, you get all these papillae pouring out, or the limbus fired like this, or sometimes all around. You know that this is a classical ocular allergy that you're dealing with, and you can treat the allergy accordingly. If there is infection, this is a slide borrowed from my father's time, where you get the blood vessels not at the limbus but away from the limbus, classical conjunctivitis with mucus pouring down, mucopurulent conjunctivitis, or in an epidemic viral conjunctivitis with bilateral red eye. He says 5 people in his office had it. So you know that you're dealing with different forms of classical conjunctivitis. And in a sorry. Thank you so much, but I had a few slides to show. I'm doing nothing, both my hands are up. क्या करेंगे इधर करने के Can you put the first slide? This is the last slide. Okay. Now I'll do it from here. So we were talking about classical dry eye, where the blink action is reduced. Computer vision syndrome patients, you stain, you get the classical stain. The Schirmer's tells you something. The TBUT is reduced. Mucus at the canthus. If you put fluorescein, the lower tier meniscus is disturbed. You look at the lashes and there is blepharitis there. So these are classical features of dry eye. So you know you're dealing with basically a dry eye patient. Now let us see the combinations. What about allergy and dry eye? It's quite common. Go with a careful history. Does the patient have itching as the only symptom, or does the patient have a burning sensation or a sandy feeling with the itching? If there is only itching, it is only allergy. If there is a burning sensation or a sandy feeling, foreign body sensation, most likely you've got a combination. How do you distinguish this? What you do is give them a therapeutic trial. You add preservative-free lubricants to the allergy treatment. Don't stop the allergy treatment. Is the patient significantly better? If the patient is significantly better, then it's a combination of the two, and long term you can continue with the preservative-free lubricants. What about conjunctival infection? The problem occurs is over-treatment of conjunctivitis, many times which lends us into problems. Most of our cases are viral, don't need the topical antibiotics. Time and again, if any book you open, viral conjunctivitis, don't treat. 95% of us treat viral conjunctivitis with topical antibiotics. Whether we like it or not, we feel we are doing injustice to the patient. We try and make it more ethical by saying to ourselves, we are preventing bacterial conjunctivitis from happening. So whatever reason may be, we treat. Or we treat because if we don't treat, the next patient will go to, will say, stupid doctor, antibiotic nahi dala. So we treat. So, but if you want to treat, go with the lowest, go with the chloramphenicals, they're still available. Go with the polymyxins, they're available. Don't go for the 4th generation fluoroquinolones, and certainly don't go for steroid combinations. They're not required at all. And if in 7 days time with your mild antibiotics, if the patient is not better, suspect a medicamentosa. It could be conjunctival medicamentosa with cornea remaining clear, or it could be a corneal as well. So then just stop the antibiotic drops, add just the tear drops and see how the patient is. Patient should start feeling better within 48 hours. Otherwise, many times the patient goes doctor shopping with about 20 different antibiotics which what started out as who knows what, maybe viral conjunctivitis, sometimes ends up with a fungal corneal abscess. So if the patient is doing better with topical steroids, and then you can gently add, if you know the patient is compliant, some steroids so as to reduce the medicamentosa. So you need to beware of this little bit of pinkish appearance, little conjunctival edema. This could all be heralding this. So these are the symptoms. Initial improvement of the patient's condition with whatever treatment you gave. Then again there is a deterioration. So if there is an improvement followed by deterioration, the natural cause of any conjunctivitis is to improve. If there is a deterioration, suspect I'm dwelling a little bit on medicamentosa because it causes more problems than the original disease. You can get SPKs in this as well. You can get chronic epithelial defects, and sometimes even you can get mimicking a viral condition with pseudodendrites. So infection with dry eye again is common. Our dry eye patients are predisposed to infection. So most of us assume that all our patients with dry eye will always complain of dry eye. When they ring up and say, I'm feeling worse, we tell them put the drops more often. And we ask them to switch to other drops. If you're putting carboxymethyl, you switch to peg tears or whatever. But dry eye patients are prone to infection, so don't give telephonic treatment, call the patient over, look for coexisting blepharitis. Unless that is treated, patient will not feel better. So a known dry eye patient presenting with conjunctivitis is not uncommon. So don't overdo the topical antibiotic because they are more predisposed to medicamentosa than normal patients. So treat aggressively for a week or so and then stop the topical antibiotics, continue with the lubricant drops. So kids are different. They often rub their eyes with dirty fingers. So you need to suspect this. You need to tell them about simple hygiene. And if there is allergy with infection, this combination also in kids is common. You need to let the allergy treatment always continue, even if you want to add topical antibiotics. So avoid aggressive steroid therapy in diagnostic dilemmas. Sometimes they suppress the symptoms, but new infections can occur. And avoid shotgun therapy, adding antibiotics, antiviral, antifungal, steroids, everything, just so that something will work. Something may work, but you won't know which one it is. To conclude, allergy plus dry eye, infection plus dry eye, and allergy plus infection can coexist. You need to recognize and treat. Avoid telephonic diagnosis. Don't overdo anti-infective treatment. You'll end up with medicamentosa. Don't taper antibiotics. There is no role for tapering. Abrupt stop of antibiotics. And beware of the medicamentosa at all times. Thank you so much.
Thank you, Quresh. I think you've beautifully introduced some of the confusions that are there. You've talked about infections and allergies and the other masquerades that are there. And oh, I'm sorry, it's on that. So I'm going to take up another aspect of dry eye disease, which is called the masquerades. This is a talk that was originally from Dr.Umang Mathur, but last minute he couldn't make it, so I'm very glad to give his presentation actually on his behalf. So as you all know, we are trying to look for that wolf in the sheep's clothing, and unless you look carefully, you'll actually miss him, and that's what this talk is all about. So this is OSD Masquerades, knowing when not to lose the way. So if one looks at dry eye, one sees that there are aqueous deficient and evaporative dry eyes. And the one that we're going to talk about is one by one, some of these features. So here's a case-based scenario where there's a 50-year-old lady who comes in with pain, redness, and diminished vision and watering. And she was okay about a month ago, but accidentally put some Ayurvedic, which is the local herbal preparations, which was a skin balm, accidentally in her right eye, and was diagnosed with a total corneal abrasion elsewhere and put on treatment for the same. And she had several follow-ups for the first month, which worsened. And so we didn't really know what it was. So we looked at the other eye, and the other eye shows this kind of a picture. So could it be the same medicine that has given this medicamentosa kind of picture, or is it something else? Diffuse punctate staining all across. Going into the history, multiple joint pains with morning stiffness since 10 years, and for which she was taking Ayurvedic medicines, with a history of dry mouth off and on. So suddenly you're looking at investigation here. Rheumatoid factor was positive, ESR was high. She went into a perforation, which was then fixed. And another case, 65-year-old, counting fingers 2 meters, had a surgery 20 days earlier. A week later came in with pain, redness, and irritation with diminished vision. Consulted his ophthalmologist who had operated the eye, but there was no improvement with medical treatment. And we looked at the other eye. There was an empty socket. What had happened there? A cataract surgery in the other eye done 6 months earlier had developed a keratitis and then had to be eviscerated. So that gives you a clue as to what's going on. There was a history of irritation and foreign body sensation in this patient even prior to the cataract surgery. So on digging further, there was a history of multiple joint pains involving the small joints of the hands 2 years ago. It's not taking any medicines. Also a dry mouth since a few years. So we're looking at probably a Sjogren's syndrome. The RA factor was through the roof, as was the ESR, which was high. And so a diagnosis of a rheumatoid arthritis with a sterile corneal melt with dry eye was made. And 3 months later, with appropriate antimetabolite treatment with methotrexate, folic acid, and topical lubrication, the vision had stabilized at 636 with some corneal scarring and pigmentation. Another scenario with a 55-year-old lady with pain and watering for a month with an epithelial defect and what appears to be an active scleritis with corneal thinning and a scar. Did the investigations, and the C ANCA was high. And the ANCA, as we all know, they are serum antibodies against neutrophils and monocytes. And these titers tend to parallel the extent and severity of Wegener's granulomatosis, and they correlate with the state of the disease. And in this patient, the appropriate treatments of immunosuppression were added, and you could see the scleritis resolving with that. 4 months later, there was a vascularized corneal scar, and a plan of phaco was made with the scleral temporal incision under steroid cover, and see what happened at the site where the phaco incision was made. There was a melt even there. So even with well-controlled conditions, you can have these kind of problems where any trauma can then lead to a melt in that area, and a scleral incision is a trauma. The diagnosis of Sjogren's syndrome may require evaluation of serum autoantibodies, including the SSA and SSB, which are Sjogren's specific, and the ANAs and the RA factors are high in all these patients, and these must be a part of the management that we do. If we look at the reflex block amongst the non-Sjogren's, we know that the absence of blinking leads to a severe dryness, and this is the nerve plexus that Dr. Rosenblatt also referred to earlier, which is in the subepithelial area. And the corneal anesthesia is really one of the most difficult forms of dry eye to treat, because when the fifth nerve is desensitized, there is a neurotrophic keratopathy which sets in, and this is just a list of some of the things that causes this ocular sensory loss. Amongst the evaporative conditions, there are intrinsic things like Meibomian Gland Dysfunction, and here's a 52-year-old gentleman who complained of persistent redness, discomfort, and watering with a history of a watering eye for the last 2 decades or so, and we could see the Meibomian gland disease. He had eruptions on the face when exposed to sunlight, and rosacea in these patients, those especially with coming in with multiple chalasia, is one of the problems, and there are various kinds of triggers such as alcohol and exposure to sun, hot beverages, etc., which cause this kind of inflammatory change in the skin. So these are some of the masquerades that are there. If one goes on, one looks at the disorders of lid aperture, and that's something that we often miss when we're looking at these dry eye patients. And is the dry eye a cause of this, or is it an effect of this? And that's something, again, in that cycle, one has to try and figure out which way it works. So this is the kind of picture one can see, and here's a patient with who has received Botox, and you can see the incomplete blinking that is happening, and this patient is bound to develop an element of dry eye because the blink reflex is not adequate and complete. If you look at extrinsic factors, here's another patient who came in with this kind of corneal picture with redness over 3 months, 36-year-old. Left eye, similar kind of a picture with a little bit of healing. Again, redness and photophobia for the last 3 months. The history of hospitalization with difficulty in swallowing food and water for a month, was diagnosed as ulcers in the esophagus and stomach. There is a history of drug abuse and alcohol. So that is something that we don't often ask these patients, but these are some of the things that one needs to look at. The VDRL was negative, the HIV was non-reactive, the ESR was high. This is the picture on the conjunctival side. Chest X-ray showed pleural effusion. He was started on anti-tubercular treatment given the scenario. The eye perforated, went in for a graft with a tarsier FE with a persistent epithelial defect. But this is the slide that probably gives it away. And what is this really? Is it OCP? Is it SJS? Is it a deficiency of some sort? It's actually malabsorption syndrome from a vitamin A deficiency given that with the drug abuse and the alcohol abuse that he was undergoing. So dry eye, as we all know, is a multifactorial disease that affects the ocular surface. And there's a new definition out from last year wherein a couple of new things have been added in. And so thank you so much. So that was some of the masquerades that are there. And when we're evaluating these patients, one must have a very broad view of the patient and the holistic approach in trying to see how the environment and how the things that this patient is doing has an impact on the dry eye. Thank you so much. To request Dr. Vanathi now to give us her presentation on the conventional management.
Thank you, sir. And it's nice to be here among you all. And I thank you, Dr. Rishi, for including me in his wonderful session on ocular surface disease. And he always gives me topics in which I can't put in any pictures or videos at all. So it's going to be most of one dry. Okay, so it's the most difficult topic when we always treat dry eye patients is how do I choose the right lubricant for this particular patient? So I'll just take you in the next 7 minutes to how you would, what are the options you probably have, and what should you choose for the kind of ocular surface disease you're treating this patient. So when you look over the counter, the options are tremendous. They are quite confusing. And considering that what you have in the drops is a demulcent, as a preservative, and a buffer agent, but how you decide on what tonicity is right and what viscosity is right for these patients. So it's again a busy slide with a paradigm shift in understanding ocular surface disease and the dry eye parameters which affect the ocular surface. And you see that this is a slide which needs a lot of analysis to look into what is the pathology which is affecting your particular patient. But now we are moving down to break this into molecular mechanisms which are affecting the ocular surface. And the need to understand the molecular mechanisms is that you will have to target the kind of drops you are using to treat the patient to deal with that molecular mechanism which is affecting and causing the ocular surface disease. That is what is going to result in the success of your treatment. So what you need to understand is how is your lubricant which you're choosing going to alter the ocular surface status in terms of altering the tear instability? How is it going to tackle the hyperosmolarity? How is it going to tackle the cell surface damage which has occurred? How is it going to tackle the inflammation in the ocular surface? And how is it going to stabilize the lipid layer? So it's understanding these pathologies which will help to work in these patients. That's why we always understand what works in one perhaps does not work well in the other. Today, the tearfil model has moved into a very complex molecular model, which has a very fine interaction of the lipid layer, the aqueous layer, and you have what is known as the NUC, or the membrane-associated mucins, which forms a complex glycocalyx on the ocular surface. And an integrity of these molecules is relevant in managing your ocular surface disease. So how do the molecules which are contained in your eye drops going to help to restore this normal molecular structure of the tear film is what is the secret in managing your ocular surface disease patients. There is again a shift in thinking in management of ocular surface disease. Earlier we treated the symptoms, so we waited for the dry eye to happen, and once the dry eye has happened, we moved on to a therapeutic modality. But today there is a shift and the need to treat the ocular surface by optimizing the tear film. So you're probably moving to treat an asymptomatic patient before the effects of the dry eye are mount to such an extent where it becomes difficult in reversing the molecular damage that has occurred in this patient. So as this diagram shows, you're now moving on from symptomatic management to managing an asymptomatic patient so that the adverse effects of ocular surface disease or the dry eye disease does not set on and makes it more difficult to reverse the molecular mechanisms which have already been triggered in causing the discomfort for the patient. By and large, most of us in our practice, we know there is a significant overlap of Meibomian gland disease when you're looking at what causes the evaporative dry eye disease and the tear deficient dry eye disease. So then you'll need to use a combination of medications, and you'll have to understand what is contained in your medication in terms of what is the polymer. Is it having a preservative? Do you need to take off the preservative in what you're treating for this patient? Does it have an electrolyte? Do you need that electrolyte for the particular patient? How is the electrolyte content going to alter the osmolarity of the tears of the patient you're treating? What is the viscous agent or the polymer which is present, and do you particularly need this polymer for using this particular patient? And of course, whether it fits the patient's pocket, and several times is the patient happy and comfortable with the molecule you've given them. So what's an ideal tear? An ideal tear is still an optimal tear when you look at it, contains all the electrolytes which are as there in the tears, where the hyperosmolarity is maintained close to what is there in that of the tears. The alkaline is slightly, the pH is slightly alkaline, viscosity is lesser than 20 CPS, and it does not cause ocular surface side effects or epithelial damage to the surface. And the polymer use is probably going to help in the retention of the tears on the ocular surface, and it is optically clear. But then this is an ideal scenario, and I look at it in a little more detail in the subsequent slides as well. So when you look at what are these drops which you're using, are they really mimicking the tears? But then it does get a little more complicated than that, because they're not just lubricating. There is the concept of osmoprotection, which is that common, which I'll just explain to you with in the subsequent slide. There are several additives such as this which are going to help on in binding and causing a mucomimetic property and help in the tear retention. And where you want to avoid preservatives in your medication when the patient has a very significant ocular disease, you need frequent applications of medicines because of a coexisting glaucoma, and there are other ocular surface morbidities. You need to look at avoiding preservatives in such patients. And again, add on or enhance your topical lubricant therapy with additive treatments by changing the formation, the topical formulation, and adding on antibiotics or the other mechanisms or environmental supports you need for these patients. So a quick look at what does the ocular, the viscoenhanced contain. It has HPMC, CMCs, carbomers, PVA, dextran, PVA, and all these. So all of them don't enhance viscosity. There are some of them which will decrease the viscosity of the, and you probably in a hypertonic tears, you're going to need something which is going to decrease the tear osmolarity. And the polymers you use follow under these two categories, aeropolysaccharides or acrylics, and you have got the newer ones which are now coming to. I'll just skip this, and I just wanted to understand what is the scientific evidence in choosing the right comfort agent for you. So I did look at this fantastic paper which does for wonderful reading, and of course their polymath derivations were a little too complex for me to understand. But when I looked at what is the comfort index of all the comfort common agents which you looked at, I was quite surprised to find your HPMC still rules higher than CMC as a comfort index agent. So that really answered my question when I always used to wonder my patients containing HPMC formulations do better than those with hyaluronic acids. So what you need to think is, where will I choose my aqueous base? What is the enhancer which I need for this patient, and what is the additive I need to use on for these patients? These are the various mechanisms by which it is really going to enhance my the patient therapy in terms of increasing the tear film, prevents the ocular surface desiccation, increases the retention of the tear. So is my tear working in all these patients is what is required. But due to lack of time, I'll just go into the diagrammatic representation. This is what a normal ocular surface looks like. And when the tear film gets disrupted, it is going to result in hypertonicity of the tears, and these will cause dryness and desiccation of the tears. When you just give a wetting agent, it perhaps helps to restore. But then when these cells have gone to the next level of hypertonicity, hypertonic tear-induced damage. It's not just enough when you just give a wetting agent, so you need to add on additives on these agents, which are probably going to restore or prevent the occurrence of apoptosis in these patients, and that will help a longer give you longer comforts for these patients in treatments. So such additives are known as compatible solutes, which are present in your formulations, and depending on assessing the ocular surface evaluation parameters, you'll need to add on whether the lubricant you're prescribing contains these additives. I did go back and look at, are there any particular prescribing guidelines? So this is probably way back in 2013, but this is the only guideline which I did find out, which I could pick on, which is available for recommendation, where you would use first line, second line, and third line therapies. But with the new DUES recommendations, I think we are now moving on to using this new molecule which is there on the block even for as a first line therapy for most of our medicine, in terms that the hyaluronic acid is a naturally occurring biopolymer, and its hyaluronate ligand binds well with the increased CD44 expression on the ocular surface, and thereby helps reduce the ocular surface damage in these patients before it's going to start occur when a dry eye decrease. So this is what is the molecular level in which probably hyaluronic acid is acting. So to summarize, you not only treat the patient in symptoms, you understand if the meibomian gland is also affected, and you're going to add on drugs which are going to give or take care of the lipid layers, and that's when you look at the tear lipid contents as well, and you add on other additive treatments which are going to take care for the tear production loss as well. So the question of decision depends upon, does it just contain the aqueous base? Do you need to give the right kind of viscoelasticity enhancer, depending upon the osmolarity of the tears of the patient you are dealing with, and the right additives as well? Thank you.
Thank you, Professor Vanathi. I think she has very nicely highlighted the different features of the different polymers that are there. And she's also indicated to us at least pharmacologically, the superiority or the difference between one type of polymer and the other. And we'll discuss this in greater detail when we look at the clinical aspects in the panel discussion, where we try and look at mild, moderate, and severe disease, that with Meibomian gland dysfunction, that with inflammatory components, and then see how we can modify our approach. I'm going to request Dr. Rohit Shetty to give us his presentation. Rohit has to leave a little earlier for another session, and so he's going to be telling us about the inflammation connection with dry eye disease. So this is some of the newer aspects in this. Ready with the?
I'm ready.
With the
It's
talk?
coming here, but it's not here.
There we
Thank you, sir. And these are my financial interests of this. When few years back, when we started working on vitamin D as one of as a role in dry eye, one of the quick questions which was asked to us is this: 70% of Indians are deficient. How does it matter? That means that it doesn't really matter, because you're just picking up one more factor in a patient with dry eye. It should not actually be a reason. However, this is what has been published, and we know it's increasing. This is an old report of 2014. By now it will be 100% or 99% of us are deficient. Then we started looking at what happens in a person who develops any disease, whether it's cancer or anything in your body. There are a few things which is important. If you look at a model, you have to have a disease specific factors, you have to have a genetic factors, and your host response. If you have one of these two, you just get a subclinical one. For example, these two things, you get a subclinical one. You person should have all the three in equal amounts to get a disease, and then that becomes clinical. Then of course, multiple other factors play in, your whole molecular signatures, the place where you live, what you eat, and the environment, how good or conducive it is to develop into a disease. This is what made us thinking. This was a paper in 2014 about how vitamin D cells are being secreted, or these markers out here tell us that the VDR, the vitamin D receptors, are present in your corneal epithelial cells. One thing we know, that God doesn't put anything without any reason. If he has to put there, that means it has to work something, it has to do something. So that's what started us thinking. Why is it there and what does it do? Incidentally, a lot of other people were also trying to figure out in the same way, but it's like the 6 blind men and the elephant, each one trying to work on one arm of it. Some people were working on goblet cells, something on pro-inflammatory cells. So our work on this, the last 4 to 5 years, was to connect all of them. And that's when we started. It all started, like any research, as a clinical observation. Then we started looking at, if we give supplements, will it work? Then we started looking at inverse relationship between dry eye disease, neuropathic pains, pain without stain, patient being very uncomfortable, not showing signs. And then probably the future is if you can reach to a stage where you can find some therapeutics which is local, because it is a local problem driven by a systemic condition. Incidentally, there were enough number of other articles about cataracts, neuritis, myopia. Myopia has got a direct link because dopamine, atropine, and vitamin D receptors all have a link. It's a very complex links, but it's all there. One day we'll probably find out what it really means. It has its important role in wound healing, but if you look at this is what happens when you have a small cut, even a few epithelial cells get abraded. This is what happens. A bunch of molecular signature or pathways do occur. If you really look at, this is from the wound healing pathway mechanism. It's not just from the eye. Vitamin D itself blocks TNF alphas, doesn't cause them to, so that there's no excessive inflammation, change in myofibroblasts so they don't get scarring. You try to work on reduction of haze. This indicates blocking. And you can see how well they have been able to create some changes. Some of it is from the work by Sham Chaurasia group, and some of it we have worked, especially this pathways, been working, but it takes a long time to prove what we are trying to say. This particular talk for the next 2.5 minutes, I'll stick to more of ocular surface and pain, because that's something which is a new arm of induced to classification. What we believe is it can do a blockage of inflammation. It can also activate an autophagy, because that helps in reducing the inflammation, and there it has its mechanism. So when you look at dry eye, when you have a perfectly normal examination, when you look at the confocal microscopies, you see nerve changes. This has all been published work by different groups, and you also have a dendritic cells. So what next? So we published this work about how dendritic cells, vitamin D, and a simple questionnaire is all connected to each other. That means a patient who comes with high level of questionnaire, which we give it in our outpatient department, they do have more dendritic cells, even though they are not, you don't see signs of inflammation. And this is what it means is, if you really look at them, there are different type of dendritic cells with different markers. And it's known in cell biology that if you look at these cells, each one of them can be, there are multiple players out here. It's not just one player. But my talk is vitamin D, so I'm trying to use that as the hero of my whole presentation. So you can see that it even plays a role in changing from a mature to the immature cell, immature to the mature cells. When you have a mature cells, that means they are trying to act someplace. So when we started looking at our tear films, there are two important things when we have pain. You have to have a pro and an anti. That means everything in our body is either pro or anti. That means one works and the other makes it to go down. So this is what we found. But the question is, what does it do? So we created a model here. This is the nerves. Imagine these are all the anti and these are all the pro. Anti-nociceptive things gets blocked so that these pro-nociceptive blocks those things. So it doesn't allow you to reach the nerves. These are all nerve endings out here. When they reach it, you get excessive firing of these nerves. And these depolarization of these nerves makes you be very symptomatic to everything. For example, in this case, they are pro. I think it's playing the same thing again. And here is a cold thermal receptor. Again, one more arm. We really do not know exact what it does. A lot of our drops works on this. So this is what happens when there is an excess stimuli, air, when patients talking more, when somebody speaks loudly, patient says that my nerve fires, and this is what really happens in these conditions. So that each and every molecule there has a reason why it is there and what it does. So finally, this mouse is not working fully. Yeah, now it's working. So finally, if you really look at the treatment, you have to treat the cause. By doing this, it changes the autophagy mechanisms, a bunch of inflammatory molecules out there, which probably indirectly it can be treated. Otherwise, all we do is we treat this. But these factors, the pro and anti-nociceptives, is very difficult to treat because you don't have a drug which can actually block it. Your steroids don't work on it. Our cyclosporins don't work on it. None of those known drugs works on this. So what happens here is when you give a treatment, we just did this experiment out here in our lab. You just look at an MMP9 with this control, and when you treat it, inflammation just by its treatment, it stops, it reduces. There is some changes out here, so it means that there's a potential role of local vitamin drops in the future. And this is just with the treatment. You can see that in our case, the dendritic cells goes, the nerves becomes better, and there's some lot more change in how the nerves are nerves start functioning. Thank you.
Thanks very much, Rohit, and thank you for the path-breaking work that you and Narayan Netralaya are doing, in helping us guide us through this vitamin D and inflammation. Any questions on inflammation from the audience? Yes, ma'am.
The oral, if I remember right, this is from the sun rays. I think each spray is 3,000 units.
Okay.
Pardon? 1,000, but they say that you use twice a, yeah.
3 sprays.
Yeah, 3 sprays. So what happens is, see, what you are giving from a physician is close to 6 lakhs unit. So it's a good question because it's not the deficiency of a vitamin which is causing the disease. It's that the vitamin D receptors on your corneal cells are blunted. They're not working for some reason. So what we feel is when you use anything which is on a low dose, it never wakes up. It's like an optic neuritis. You give oral steroid, doesn't work. It has to be a bolus dose. A bolus dose, when you give a bolus dose, what happens is the vitamin D receptor starts activating. So you can use it for a maintenance dose once you reach it, but not as a treatment. That's my call on this. I don't know, but that's from a science angle. A bolus dose makes your vitamin D, that's called VDR, vitamin D receptors, that gets upregulated.
Okay. Thank you, sir.
Any other question to Dr. Rohit before he moves on? So currently, is there something that you would recommend in terms of dosing in case you have someone where you think there's a refractory dry eye and there is an inflammatory component?
What my physician gives us, he gives 6 lakhs international unit intramuscularly, and then he sees them. I think there is 3 more doses spaced over a month, and then he maintains them at upper limit of normal.
Right.
And that is for people, like I said, you have to be very good with your physician. You have to tell him that these patients do not respond to your oral treatments. They're on sachet for a long time, just doesn't work. The reason is, what I just said, your vitamin D receptors only gets triggered off with the bolus dose.
And what serum levels would you define
upper
as?
Limit of 40.
Upper level of 40?
Yeah, because more you give, if the patient is predisposed to a renal stones, there is a chance that they may get a renal stones. And the active form of vitamin D which you are giving bypasses your whole metabolism. So again, there is a chance that it reaches its faster.
Any other questions? So thanks very much, Rohit.
Thank you, sir.
And thank you very much for being on this course with me. Thank you. So we're going to move on now to the next talk, which is going to be on hyperosmolarity.
So Dr. Vanathi referred to this, the role of osmoprotection basically. This all came about when we got drugs which had compatible solutes in them. And therefore, Rishi to tell us about the role of hyperosmolarity and osmoprotection.
Can we come on screen, please? Yes. So thank you so much, Quresh, and thank you everyone for being here. I'm happy to see a full hall. It's always a delight to being addressing a full hall. So Dr. Vanathi touched on this briefly when she was giving us her talk, and she talked about the osmoprotectants and the hyperosmolarity issue. So this was something that was introduced as a concept in 2007. So it's been 10 years now. And I think gradually even the drug manufacturers have started to understand the importance of the additions of certain elements in their products which would help us do this. So is it a myth or a reality, really, all this talk about osmoprotection and hyperosmolarity? So we know that there has been this paradigm shift, and that both hyperosmolarity and inflammation of the ocular surface have been added to the definition of dry eye. And this was the definition in which these were added. Of course, there have been more additions from as of last year on the basis of homeostasis and the neural instability aspects. So we'll discuss those later. So we know that when the proportion of water to the solutes in both the tear film and inside the cell are the same, the system is said to be in an isotonic state. So this is how we would ideally hope our ocular surface cells to be. But when there is a loss of water, there is a shrinkage or a desiccation that happens as these cells become dehydrated. And when the tear film is healthy, it maintains a constant osmolarity. But when there is a dry eye, the quantity of water in the tear film goes down because of high evaporation or because there was an insufficient water in the first place. And because there is less water in the tear film, the concentration of the solutes such as sodium and potassium increases, and this raises the osmolarity, upsets the isotonic balance and between the tear film and the ocular cells. So this is how the healthy eye is. It's pretty much between a 296, 302 milliosmoles, which is the same as blood. But in dry eye disease, this value is generally higher than 316 and can go up to 360. But it's suspected that the spikes on the corneal surface are probably 2 to 3 times that, because we are measuring the osmolarity in the tear meniscus, which is close to the canthus, whereas on the ocular surface itself, there's far more concentration of these salts than what we can actually examine in clinical practice. So this was one of the animations that we saw earlier, where when there is water loss, there is a dehydrated cell, but you can't have a whole tissue shrinking. So what does the cell do? It does what it calls regulatory volume increase. And it does that by imbibing certain salts, so the cell volume gets restored. But what also happens is that it brings in too much of sodium, potassium, magnesium, and all these electrolytes, and this causes a decrease in cell function because there's now hypernatremia and hyperkalemia within the cell, and that produces cell damage and apoptosis. So this is the vicious cycle that is there now, and I've just taken the major parts of this, wherein tear hyperosmolarity here is what adds to this whole process, leading to apoptosis of the ocular surface. The ocular surface damage starts fairly soon, and within a day and a half, there is activation of the stress kinases, and from acute epithelial disease, it becomes chronic surface damage with the involvement of the T cells, and that happens usually within a week of the onset of the hyperosmolar stress. So what happens, and how can the cell help itself by not going through this process? Now, we knew that there was a regulatory volume intake and there was cell death because of apoptosis, but there is another column or another mechanism that the cell has, which is that it can bring in a regulatory volume intake, which is by what we call compatible solutes. And compatible solutes are essentially molecules which will bring in osmolar power without interfering with cell function. So they are essentially substances which do not involve themselves in the cell metabolism, and these are called osmoprotectants. And these are found in many, many tissues inside the body, especially the heart and the kidneys, where there's a lot of hyperosmolar stress. But unfortunately, the ocular surface does not have the capacity to synthesize compatible solutes. And so these compatible solutes have to be provided externally. So these are some of those that are available in various species in nature. They are the methylamines, they are polyols, they are amino acids and small carbohydrates. And some of these are now being introduced into these ocular fluids that we have, that we can use as eye drops for supplements. So the goal of treatment in DED is to improve the patient's quality of life and symptoms, and to prevent the patient from entering the vicious circle, or to promote the exit from there, and to prevent anything entering into the circle which is a causative factor such as environment and other systemic disease, and promoting the exit from the vicious circle, which involves addressing the central mechanisms such as tear film instability, inflammation, and tear hyperosmolarity. And there's an expanding pool of clinical data that suggests that osmoprotectants are fairly effective. Glycerol and erythritol, for example, are small polyols. They work very quickly through the water channels, but they also leave very quickly. In contrast, the amino acids like carnitine, which are taken up via amino acid transporters and are retained for longer periods. And it are these kinetic properties, when they're properly balanced, that makes a product or a tear film substitute ideal. So you have very rapidly moving items, medium speed of moving items, and those which have to be actively transported across the cell membrane. And it is the proper combination of these which works to make an overall protection better. The lab studies have shown that these osmoprotectants are very effective. Here there's a study which showed that the activation of these enzymes was reduced in the presence of osmoprotectants like L-carnitine and erythritol. There are more that have shown that there are a reduction in the expression of the enzyme stress at various osmolarity levels when these human epithelial cells are cultured in the presence of these osmoprotectants. And there is clinical evidence as well, and there are various studies which are showing the comparison between drugs which contain osmoprotectants versus those that are not, and they're showing that the comfort as well as the OSDI scores are better. There's a switchover trial with more than 5,000 dry eye patients which revealed that there was a better ocular comfort, improvement in clinical signs and symptoms after a few weeks, and an improvement in the T-butt or the tear film breakup time. So the ordinary artificial tears that we have are only surface active, but those that contain osmoprotectants are actually adding to the value intracellularly as well. Evidence are getting more stronger and more compelling, and the role of L-carnitine in protecting the ocular surface is there, and we know that the L-carnitine levels are much lower in patients with dry eye, and thereby I think the possibility of supplementation even orally can then be considered. To summarize, dry eye is produces significant ocular surface damage which is mediated by hyperosmolarity, and which is one of the key mechanisms in the evolution of the dry eye. And cells ordinarily use short-term inorganic solutes and long-term compatible solute regulatory environments. Hypotonic solutions provide only very transient relief. Compatible solutes help regulate the osmolar balance and provide osmoprotection, and there is mounting clinical evidence of the beneficial effect of all of these, and incorporating compatible solutes with different kinetic properties may be more effective in protecting patients from dry eye. Thanks very much. I'm going to now request Professor Rajesh Sinha, and he's going to be giving us his talk on Meibomian Gland Dysfunction, and we'll also be discussing certain newer paradigms, as well as we'll move into the realm of molecules, and he'll be talking about chloroquine.
Thanks, Dr. Rishi, for including me in this course. I'll first be talking about Meibomian Gland Dysfunction. Well, this is a very common disorder, a very common problem that occurs in, that we face in our day-to-day. The slide is not changing. Yeah. In our day-to-day practice. And in a routine Meibomian gland dysfunction, we can still manage with lubricants, a little bit of warm lid compresses, but there are many scenarios when we get to see these refractory MGDs which don't respond. You have cysts in the lid margin, and all these are a major problem. It can be associated with, altered secretions, heaping up at the edge of the Meibomian ducts, and then when you examine the glands by mammography, you see that the glands drop out, and the patient has increasing symptoms. And all these things are more often seen when you see that an old individual coming to your OPD, and when you see invariably many of these individuals, they have this MGD. So increasing age is a factor. Of course, contact lens wear, hormonal imbalance, particularly in females. Poor hygiene is very important. And of course, environmental factor is really coming up very fast these days, and people are knowing about it, that these are causing problems. And of course, individual susceptibility is an issue. Acne rosacea is another important cause of severe MGD. So if you have an MGD which is not responding to your routine treatment, that you can consider it as a refractory MGD. Now, what is the routine treatment of MGD? Well, any patient, if you examine the lid margin, see heaped up secretions. Obviously, you initially start with warm lid compresses and then a little bit of lid massage that can be done by various methods. And you give some anti-inflammatory agents to take care of it. So if all these routine measures, they don't work, then you go further. And what is that further? You start oral doxycycline. Now, there are a couple of studies which have compared the various dosage of oral doxycycline. Now, this is the earlier established the dosage was 100 milligram twice a day for a week, followed by 100 milligram once a day for 6 weeks. Now, there was a study which, a major study which compared this dosage with 100 milligram once a day from the very beginning, and they found out that the result was similar, comparable. So these days, people are preferring 100 milligram once a day oral doxycycline for 6 weeks. And of course, there are certain topical immunomodulators which are very useful, like topical steroids and topical cyclosporins, which again they help a lot in managing these cases. Now, if there is acne rosacea, ocular rosacea, then of course doxycycline is very useful. You should also take some preventive measures, like you should avoid products that contain alcohol, menthol, exfoliating agents. You should avoid cosmetics, too much of cosmetics, and you should use protective goggles, etc. And as I said, oral doxycycline is very useful in MGD. Oral omega-3 fatty acids is also showing very good results these days. And some people have used, some studies have shown good results of topical metronidazole gel as well for these. But what is most important is that you have to do an active expression of the secretions, because these are clogging the ducts of Meibomian gland. And for that, you do warm lid compresses, you do a little bit of massage. If that doesn't work, then with the help of a swab stick, you can press, you can do probing, and you can get out the secretions. You can even use a simple spatula, and that helps to keep the lid surface on it, and then you can do a massage. You can oppose the two lids as well and then do a massage. So there are various ways. The basic idea of all these methods, all these expressors, is to express the secretions that have clogged up in the ducts of Meibomian gland. And this is an upcoming method which is becoming quite popular, although a little costlier. But this LipiFlow method is, you provide heat simultaneously and you do a thermal pulsation. You have a thermal pulsation system. So as you can see here, you provide heat from inside the plate. Do you have a pointer? You provide the heat from inside and you have a thermal pulsator from outside the lid. So in that case, you have a simultaneous heat and pressure, and that really helps in expressing out the Meibomian secretions. And there are certain lid scrubs as well, because many times you get these secretions to form crusting over here. And even if you express it, even if you press it, it's not going to get expressed out. So you have to use the scrub to remove these crusts from the lid margin. That is very, very important. And it's a sort of a disease which is treated by lifestyle modification. We require some change in diet. We can use fatty fish. We can use humidifiers. If all these things are not, very much working, you can take omega-3 supplements as well, as I said, because these are really useful. Of course, along with that, we can have other problems of lid related to Meibomian gland dysfunction, and that has to be handled. Handling chalazion or trichiatic eyelash, entropion or ectropion, that can happen in Meibomian gland dysfunction as well. So what is most important in Meibomian gland dysfunction is explaining the patient to adhere to whatever you are guiding, because it is very easy to put the drops, it is very easy to take the tablets, but to maintain the lid hygiene, which is the most important thing, expressing the secretions from the ducts of the Meibomian gland, which is most important thing. These things one should adhere to, and of course, if there are crusts at the orifices, that needs to be removed by these scrubs. And a combination of all these factors like interventions, environmental factors, dietary factors, and the eye drops, as well as sometimes you have to do some probing, etc. All these factors, depending upon the severity of Meibomian gland dysfunction, is essential in order to have a symptom-free patient and resolution of symptoms. Thank you very much. Can I have the next one, please? Can I have the next one? Next presentation. Yeah. Go here. So, are you doing or shall I do? So, I'll be talking about post-surgical ocular homeostasis. Now, we are all surgeons. We all, some of us are refractive surgeons, some of us are cataract surgeons, some of us are corneal surgeons, some of us are retinal surgeons. I mean, we have a combination, the whole gamut is here in this meeting. So we all are very keen and very fond of doing surgeries. And what are the issues that we have after a successful surgery? What we want? As an ophthalmologist, I would like to have a good visual outcome, and all of us want that. If we have done a cataract surgery, we want the IOL to be absolutely well centered. If we have done a retinal surgery, then we want the retina to be settled. Glaucoma surgery, we want a nice bleb and a normal IOP. And if we have done a refractive surgery, we want a good visual outcome and the flap to be absolutely normal without any stria or dislocation, etc. And once we get all these things, we are very happy. But what happens is that some of the patients are not very happy. We may say that the results are very good, but the patients are uncomfortable. Why? Because they have the symptoms of irritation, redness, foreign body sensation, and these things are becoming very common these days. And earlier, the issue of getting 6x6 vision was the major criteria of having a successful surgery. But now we want the patient to be happy, we want the patient to be comfortable, because the 6/6 issue is no more there. So what is the major factor that causes these symptoms? The major factor is that all these symptoms are ocular surface related. So there is something wrong in the ocular surface homeostasis. And what we found out, people have found out that this disturbed ocular homeostasis is basically because of inadequate ocular surface hydration. Now, why we do have inadequate ocular surface hydration? Suppose we have done a LASIK surgery. What we do, we create a flap, we cut the nerves, we put the drops. This is the normal neuronal flow, loop which requires for a normal tear secretion. But if we cut the nerves, it cuts somewhere, and that creates reduction in tear film. And this is one survey which was done on the patients who were dissatisfied with LASIK. And 1 out of 5 individuals were dissatisfied because of ocular surface disorder. So that comprises of a very huge proportion. Then after cataract surgery also, people have found out that patients are symptomatic. And why? Because of disturbed ocular surface. Then people thought that, and it affects, because these days we are implanting premium IOLs, and the results of premium IOLs, they get affected if the ocular surface is not good. Why they have it? Because most of these patients are old, and they are already, they are predisposed to Meibomian gland dysfunction, disturbed ocular surface. Some of these are perimenopausal females because of hormonal imbalance. Some of these are having Meibomian gland dysfunction, as I was discussing. Some of these patients have coexisting glaucoma, and they are taking anti-glaucoma medications, which are very, which play a major factor, major role in causing ocular surface disorder. And of course, when we do a surgery, we alter the corneal curvature, so the breakup time becomes fast. There can be inflammation. You cut the nerves as well. You do additional procedures, like we want a 6/6 vision unaided, so we want to correct the astigmatism. So we do LRIs and all these corneal incisions. We cut the nerves further. So what happens? That there's significant corneal anesthesia, and that causes reduction of tear film. Now, if we have done a glaucoma surgery, we are happy with a nice bleb and a normal IOP. But we have used antimitotic agents, and that can cause surface toxicity. We can cause limbal stem cell deficiency because of damage because of antimitotic agent. We can have a large bleb with a normal IOP, but that can cause breakup of tear film just adjacent to the bleb. Now, if we have done a retinal surgery, what do we do? Many of the retinal surgeons, they debride the epithelium very vigorously. They can damage the stem cells as well. They can cause conjunctival damage, goblet cell damage. And this is one study that was done in Japan, and they found out that there is phototoxic effect of an operating microscope on the ocular surface and tear film. So that is also one factor. So all these factors can cause this ocular surface disturbance. Now, this is one study which found out that this was a ocular surface disorder after vitreoretinal surgery, and they found out that there was a positive correlation of injection of silicone oil with the causation of ocular surface disorder. Now, we use so many drugs after surgery, and that can also have its toxicity. So all these factors, recently there were a couple of studies done, and they came out with a quotient that is called ocular hydration and homeostasis quotient. The basic idea of making this quotient is to have an objective criteria of measuring the severity of disease. So all those factors which support the ocular surface, they are on top, and the factors which they don't support, they are on the bottom. And if the score is more than 1, then this means that the person is having good ocular surface. If the score is less, then it is a disturbed ocular surface. As Dr. Vanathi has very nicely mentioned about all the lubricants, which polymer to use, so I'm not going to do that. So preservative-free lubricants is the key. We don't want preservatives. Carboxymethyl cellulose, sodium hyaluronate, all these factors, compatible solutes which Dr. Rishi was mentioning. So all these factors are very essential to bring comfort to the patient as well as to improve the epithelial surface. The topical steroid and cyclosporin to reduce inflammation. Dr. Rohit Shetty was mentioning about the inflammatory, role of inflammation in causing dry eye. And it's a fact which is a known thing, and there are various factors. So inflammatory mediators are there, and for that cyclosporin and doxycycline and omega-3 fatty acids are very crucial. There is an emerging concept these days. People are more focusing on surface epithelial cells rather than focusing on the breakup time or the Schirmers. They found out that apoptosis is a very important factor that causes symptoms. And the symptoms of dry eye disease is caused by apoptosis. That's a known thing. And UV rays are one which are responsible for causing apoptosis. So a couple of studies have found out that chloroquine phosphate is quite useful in dry eye. How? Because it can reduce apoptosis. Now, it's a known antimalarial drug, and it was found to be useful in Sjogren's. They found out that systemic hydroxychloroquine, I'll just take half a minute more. Systemic hydroxychloroquine was associated with improvement in dry eye symptoms in Sjogren's syndrome. So that brought the concept of use of chloroquine drops. Now, how do they act? There are macrophages, neutrophils, dead dying cells, and they liberate metalloproteases. Now, what happens? It results in apoptosis of immature surface epithelial cells. Now, chloroquine acts here, so this prevents apoptosis. So that is the key of apoptosis. So that's how it brings about a photoprotection. And it has been found to be effective in experimental animals. It was even safety studies were done, and they were found to be safe in animal studies, and then they started the human studies. And in human studies, they found that it is quite safe to use. Then they did the efficacy study, and they found out that there's better Schirmers, improvement in Schirmer's test. There was a good improvement in breakup time. There was improvement in Schirmers, as I mentioned. The fluorescein staining of cornea reduced with use of chloroquine. The symptoms of dry eye reduced. The microscopic examination showed that the apoptosis was less. And they concluded that chloroquine eye drops have a favorable effect in dry eye syndrome because they reduce apoptosis. So, and the study summarized that chloroquine phosphate eye drops is a therapeutic approach for the restoration of tear formation for dry eye disease. So, I would just like to conclude here and conclude both my talks by saying that ocular surface disorder is something which is a multifactorial. So, we need to have a multifactorial or multiple prong approach, multiple armed approach to handle this ocular surface. Preservative-free lubricants with, of course, those compatible solutes and good hydration polymers are essential. To reduce inflammation, we have the topical cyclosporins, steroids, and omega-3 fatty acids. We need to take care of the lid hygiene by expressing the secretions of Meibomian ducts. And of course, to prevent apoptosis, topical chloroquine phosphate is now coming up with good results. Thank you very much.
Thanks so much, Rajesh. I think you've very nicely highlighted both MGD and you brought in chloroquine. Come and join us back here. So we're going to request Dr. Vanathi to carry on this discussion on molecules, and she's going to be talking about now a time-trusted molecule for the last 25 years, which is cyclosporin, and its role in dry eye disease. And after that, we'll conclude the session with Dr. Maskati giving us a talk on Rebamipide, which is a newer molecule which has been out for the last 3 or 4 years now and is very useful in inflammatory dry eye. Dr. Vanathi.
Yeah. Thank you, Dr. Rishi. So I'll quickly run through the cyclosporin uses. Is it worth its salt? And as Dr. Rishi rightly pointed out, that it's been in use for quite a while right now. But then we need to understand how is it working, and when will it work, when do you need to prescribe topical cyclosporin in dry eye disease management in your patients. So again, it boils down to understanding the molecular mechanisms. When you need to use the anti-inflammatory and the immunomodulating effects of topical cyclosporin on the ocular surface to help in the therapeutic effects in dry eye disease. So by and large, we still use the simpler ocular surface evaluation tests in our management modalities, and these would be probably enough to sort of decide the level of dry eye you're looking at in your particular patients. When you look at cyclosporin, it is a neutral hydrophobic cyclic peptide amino acid molecule, and with a given molecular weight as depicted here. But how does it really act? It acts as it acts by inhibiting interleukin-2 release from activated T cells. Well, that's a lot of immunology to understand for most of us. So just to simplify it down and make you understand at what molecular level does this molecule act, otherwise your treatment is going to be a failure when you just prescribe this for your patients. Basically, the T cells are of 3 types. You have the helper T cells, you have the suppressor T cells, and the killer T cells. The helper T cells or the CD4 destroy infectious organisms. The suppressor T cells help to prevent or suppress the activity of other lymphocytes so that the normal tissues are not damaged. But when you look at cytotoxic T cells or the killer T cells, these will recognize and destroy the abnormal or the infected cells. So there is a fine balance between these 3 which exists in the system. So when there are activated T cells, they release a lot of interleukins or inflammatory mediators, and this is the level at which cyclosporin acts. It's a powerful T cell modulator and inhibits T cell from producing toxic mediators. So when this molecular mechanism is existing on the ocular surface and is resulting in damage, that is when you probably need to add on the cyclosporin for these patients. Otherwise, these patients are not going to be very happy with these medicines. The fact is that the inflammation levels have gone to such extents, and there is hypertonicity of tears, and if you add on a cyclosporin at this level, as in severe dry eye patients, the patient is going to immediately reject your prescription, coming back telling you cyclosporin per se also causes a lot of stinging when you use it on the ocular surface. So in hypertonic tears environment, you're going to prescribe a topical cyclosporin. The patient is not going to be compliant to usage. So the ideal or the potential candidate to whom you need to prescribe topical cyclosporin is when you're looking at probable moderate dry eye patients. You've already treated them with, or they are on treatment with lubricant therapy, you take care of their inflammatory status to bring it to an acceptable level, take care of the hypertonicity of the tears, and then add on a cyclosporin topical medication is when you're going to have a successful management of using this molecule, and cyclosporin becomes worth its salt in such a scenario. So you need to know when you need to add on cyclosporin. So why cyclosporin? You need to give it for a longer period of time, and when cyclosporin, it acts as a steroid-sparing agent. It does not have the effects of on raising IOPs or damaging the wound healing mechanisms. So it's not iatrogenic. It's particularly effective in patients who are contact lens intolerant because of the dry eye disease that has developed. In a profile of allergic diseases like VKC, eczema, atopic keratoconjunctivitis, and of course in superior keratolimbic conjunctivitis as well. But always remember, you need to proceed this with adequate amount of lubricant therapy, bring down their inflammatory levels to acceptable levels, take care of the tonicity, then add on cyclosporin. That remains the secret. And also cyclosporin needs a particular period of time. It's not a rapid acting, and it needs about at least 12 weeks before its therapeutic effects are going to come into vogue. So you need to keep these mechanisms in place, and you need to keep the therapy on for these patients. So compliance is a major issue when you need the immune modulating anti-inflammatory effect of cyclosporin to come into action in these patients. So we did do a molecular level study. We did an in vivo confocal microscopic study and comparing prospective comparative trial when we looked at a group of patients before and after cyclosporin therapy in ocular surface disease due to chronic anti-glaucoma therapy, and we imaged their subbasal nerve fiber layers and took them on to look at the counts and the amount of fibers, and this is what we got, and we did find striking significant results that topical cyclosporin therapy does add on and help when you're looking at chronic ocular surface diseases by means of its immune modulating and anti-inflammatory effect. Thank you. I think I'll stop here and move on.
Thank you, Professor Vanathi. I think she's very nicely highlighted the value of cyclosporin in management of dry eye disease. She's also mentioned that it doesn't start to work the moment you start to use it, and so that's important to remember, and it's important to counsel the patients accordingly, that there is going to be a while before we will be able to get a benefit. Dr. Maskati.
Thank you. I have only 56 slides. The current topical treatment for dry eye syndrome, we found that there is a 76% decrease in goblet cell density in dry eye syndrome. So therefore, logically, anything which improves the proliferation of goblet cells and improves the mucin component should be a good enough logical add for a dry eye patient. Rebamipide comes from a mucin secretagogue accidentally discovered in Japan because it worked for peptic ulcers. So Santen, the company which started it, said let's try it as a suspension, 2% in the eye, and that's how it came in. It does, it improves the microvilli. The microvilli are the building blocks on which the mucin sits. So if the microvilli are stronger, longer, taller, then as the base of the tears will be much better. So if you see these slides over here, the number of microvilli and the length of the microvilli increase with the Rebamipide. So it therefore improves the microvilli and the goblet cell proliferation as well. It also prevents damage to the microvilli. So it has multiple ways by which it ensures a firm adhesion, and therefore the base of the tears is stronger. In various in vitro studies, it has been seen that it prevents not only to the microvilli and the goblet cells, but also upregulates the expression of membrane-associated mucin. In one of the earlier talks, we talked about different types of mucin. The MAMs, or the membrane-associated mucin, is also improved and increases mucin-like glycoprotein production in the corneal epithelial cells. So not only goblet cells, but the corneal cells secrete a glycoprotein which is like mucin. And it also, as a side effect, suppresses inflammation. So it can be used in vernal conjunctivitis as an adjunct. So therefore, it acts at various places in the tear, the pathway, and that's why it's been said that it gives 360-degree benefit. And several studies have shown that when you use it for various, one eye, getting the Rebamipide, 1 drop in each eye 4 times a day for a year, and looked at the fluorescein staining and the lissamine green staining and the tear breakup time. Just these three parameters, it was found that the fluorescein staining reduced. So you can see that the green is the reduction, the lissamine green staining reduced as well. So this is the before and after picture showing you this. And the tear breakup time improved. Not so great, but it did improve to some extent in these patients. Most importantly, the symptoms. When you ask the patient how they felt, at baseline at 2 weeks is the red, and the green is the at 52 weeks or a year. Most patients felt better as far as foreign body sensation, dryness, photophobia is concerned. So Rebamipide does improve the signs as well as the symptoms, and it works even in severe patients like the Sjogren's syndrome. Dr. Vanathi told you about how in very severe cases cyclosporin is of no use. So this tends to work. Important thing, it has to be put 4 times a day for 4 weeks minimum before you declare the drug as not working. So the same thing in Sjogren's, I'm going quickly through that it has the same effects as I showed you in the previous. And as I said, quite by accident, they found that in vernal keratoconjunctivitis, which works where only steroids work, if you added this, your dependence on the steroid reduces. So patients can be treated not with Rebamipide alone, it doesn't work, but whatever anti-allergic treatment you're giving, whether it is Alcarex or whether it is Bipotestin or the Patenolol, whatever you're using, or Epinestine, if you add this in cases which are refractory, it does tend to help in some of them. So it does attenuate the giant papillae, so it can be used. To summarize the indications of Rebamipide, dry eye disease as well as an adjunct in allergic conditions. Remember, it's important 4 times a day, minimum 4 weeks before you say it's not working, so tell the patients to have some patience. There are no life-threatening adverse effects, but about 15 to 20%, not the 9.7 as reported, but in my series, about 15 to 20% complain of a terrible sensation in the throat. Very, very bitter taste in the throat, and I've had to stop it in about 15 to 20% of cases. So if it occurs, you've got other drugs to use. Don't persist with it if you get what is called dysgeusia. Otherwise, it's fairly well tolerated. So it increases proliferation of goblet cells, increases production of mucin, therefore the tear film stability is improved, improves the breakup time, decreases the hyperosmolarity, decreases the inflammation, and gives you a 360-degree effect. Quite well tolerated, except in about 15 to 20% where you get a very bad sensation in the throat. So it's one more molecule having a definite role. This is the Gujarati thali that we have in Mumbai and in parts of Gujarat where several dishes are served. We have several things we've talked about in this session. So it's one more molecule having a definite role. Let's use it judiciously in helping our dry eye patients. Thank you so much for your attention.
Thanks very much, Dr. Maskati. I think he's brought out the Rebamipide molecule and its advantages very well. There are more molecules on the anvil in our fight against dry eye and trying to make our comforts better. I think Lifetigrast is going to be introduced very shortly. I'm sure Dr. Rosenblatt is here. Maybe he has some experience with the use of Xiidra in the US. Right.
That's also beneficial. It's a little bit more specific in terms of its target. It's not a pan-T cell inhibitor. It's an LJ1 antagonist, so it may help with other substitution that aren't helped by our other immunomodulatory drugs.
Well, thank you so much. That's wonderful, and I'm sure we'll get a similar experience once we start using it here, and we'll have that with you in this course next year, hopefully. Dr. Maskati, any?
Thank you. The other one which is been touted as very useful is topical androgen drops, which is with allergen, and for some reason, I think possibly because they're promoting their cyclosporin, they've kept it on the back burner because it's been about 10 years since I've heard about the topical androgen drops, and they still haven't come in. It'll be very good for the regulation of the lipids, especially, which we don't have too much. But commercial considerations, according to me, are keeping it away from us. Let's hope it comes through. Thank you so much. And thank you all for being such a magnificent audience. Thank you.
Thank you, everyone. I think the next session is on glaucoma. They're raising the pressure here for us to leave. So thanks so much.